This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. You know, every time we hope to try to put COVID-19 in the rearview mirror, something new happens. We're delighted we're going to have with us again today Dr. Robert Haley, Professor of Internal Medicine and the Director of the Division of Epidemiology in the Internal Medicine Department at UT Southwestern Medical Center. Dr. Haley, welcome back to the show.
Very happy to be back with you, Steve.
You know, I think it'd be good for our listeners to understand what really causes variants. Why do variants occur with COVID-19?
Well, this is the natural way that these types of viruses behave. They tend to change over time. There are really two kinds of viruses: those where their genetic material is DNA, and those that are made by or have a genetic material that's RNA. That may be not clear to a lot of people, but they're very different viruses. The DNA viruses are very stable and don't mutate very much because their DNA has a spell checker in it. So as the virus reproduces, the new viruses that produce, if they have a mutation, this spell checker finds the mutation and causes the virus to die. And so it prevents mutations from occurring. So these are very stable. The RNA viruses, on the other hand, are more primitive viruses, and they lack the spell checker. And so when they reproduce and produce new viruses, if they contain new mutations, they'll just go right on. If the mutation doesn't kill the new virus, it will persist. And so these RNA viruses just mutate constantly. And that's the case with COVID. It's a typical RNA virus that mutates at a moderate speed. And the more people that get infected and the longer they stay infected, the more these mutations occur just on a random basis. And then when millions and millions of people are infected, then you've got just the numbers indicate you've got a real good chance of finally selecting out a mutation that really gives the virus a selective advantage in surviving and outcompeting the other variants. And if you get one of those, then it sort of reproduces rapidly and takes over and just crowds the others out and becomes the dominant strain. And that's what's happened one after another with the coronavirus, the COVID-19 virus. We had the original strain that came in March to the United States, really in February and March of 2020, and that spread rapidly around and was moderately virulent, meaning made you moderately ill. But then it pretty quickly we got a new variant from England that was ultimately named the Alpha variant, and there undoubtedly had been millions and millions of mutations, but most of them had not provided a selective advantage and had not caught on. But Alpha suddenly had a mutation that allowed it to outcompete the original strain, so it became dominant and crowded out the original. And then we had the Beta strain came along, but the Beta didn't compete very well. It caught on for a while, but didn't. Same thing with Gamma, didn't compete very well. And then we got Delta. And of course, Delta just right away, within several weeks, had taken over and crowded the Alpha variant out and became the dominant strain over the world. And that's where we are right now, except now in South Africa, just 2 weeks ago, just a little over 2 weeks ago, this new variant was identified in South Africa, and it seemed to be spreading rapidly. And so it got the name Omicron. Well, you know, Omicron is toward the end of the Greek alphabet, and So between Delta and Omicron, there were a lot more named variants, but they just never caught on. And finally, we got Omicron coming along, and it's competing very, very well. Looks like it may have taken over from Delta in South Africa, or is on its way to doing so, and it's now spread around the world. In 2 weeks, we've gone from seeing none in the United States to having isolates in, I think, 24 states now already. And undoubtedly it will be, in fact, just in the last couple of days, we've seen the first variant in Texas, I believe down in San Antonio. And so it will take over and perhaps crowd out Delta, or they may coexist for a while. But that's sort of the history of what got us here.
Right. And we know how serious Delta is. So I know there's still research being done on Omicron, and I know there are a lot of answers that we're going to probably have in the next 2 to 3 weeks. But in your professional opinion, how contagious would you say this is?
From the reports of South Africa and the way it's spreading around the world, this appears to be highly contagious, probably even, well, I think certainly now we know it's more contagious than the Delta variant, which, of course, was very, very contagious. And this is probably almost certainly much more contagious than Delta.
Now, being contagious is one thing. Do you have enough information yet, or have you gleaned enough from South Africa to address the severity of this variant?
Yeah, there are really two issues there. One is it able to evade our existing immunity, either from past infection or from the vaccine? And if it is, then a lot of us will get infected. And then the question is it going to put a lot of people in the hospital? Is it going to kill a lot of people? Or what? And, of course, we don't know the answers to those because we've only known about this thing for a couple of weeks. What's emerging now is that it can evade immunity to a great extent, but it does not appear to be causing as severe an illness. Now, I don't want to be too strong on that because it might be just as virulent or more virulent than Delta, but it's just so early we don't have enough experience to have detected it. You know, normally with Delta, when you get infected, it usually takes a week or 10 days before you get really sick. And then once you get really sick, it takes you a few more days before you actually go to the hospital. And then after that, it takes you another week or so before you get really sick, so you have to go to the ICU. And you may stay in the ICU for a month before you die. And so since we've only known about this for a couple of weeks, we still may be very early in that time course, and we may start seeing a lot more severe illness as time moves on. So we don't want to conclude this thing's going to be a patsy because it may be pretty severe. But right now, if we had to make our bets, we would say it's actually going to get more benign.
We're listening to Dr. Robert Haley. Glad to have him back on the human side of healthcare. He's the professor of internal medicine and director of the Division of Epidemiology at UT Southwestern Medical Center. Been a while since Dr. Haley has been here, so we're going to pick his brain on several other things relative to where we are now. Can we ever end this thing, and what will COVID look like, perhaps, a year or two down the road? All of that next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. Rolling right on in now with part 2 of our interview with Dr. Robert Haley from UT Southwestern Medical Center and Parkland Health and Hospital System, picking up where we left off about what happens when one variant turns into another, like we're seeing happen now.
You mentioned in one of your answers, and I think you used South Africa as an example, where now the Omicron is the more dominant virus, even more so than Delta. For our listeners to understand, if Omicron becomes more dominant in a region or a community, does the older viruses or variants die off?
They don't die off per se. It's just they no longer will infect other people because Omicron will have beat them to it. But that takes a while. So I think even if Omicron turns out to be more highly competitive than Delta and will eventually crowd it out. For the next month or two, we're going to see plenty of Delta. Delta is going to be our big problem, and we all know how that is. That is highly infectious and produces severe disease and is quite capable of killing you. And the people that's infected are mostly people between 30 and 64. Over half of the infections we're seeing with Delta right now are in middle-aged people, 30 to 64, and that group is not as highly vaccinated. And what we're seeing is in vaccinated people, Delta is not producing severe disease, or rarely, but in unvaccinated people, it's producing very severe disease and putting people in the hospital and the intensive care unit still. So the idea is, regardless of what's going to happen with Omicron, anybody who's not vaccinated needs to get vaccinated, and anybody who's fully vaccinated needs to get their booster, because all of those things will keep you safe, at least from getting sick and going to the hospital, whereas previous infection will probably not protect you from this Omicron.
Do you think the current vaccinations that we're using will be effective against Omicron, or is it too early to tell?
We don't have a definitive answer, but knowing how these things work, the prediction is the vaccine will continue to be highly protective, at least protect you from having to go to the hospital or from dying. And here's why. Picture on this virus, everybody's seen a picture of the coronavirus, and it's this round ball with all these little projections, these little things sticking out, little spikes sticking out all around it. Well, those little spikes are called the spike protein. And the spike protein is what allows it to hook up to your cells down in your lung and then invade your cells and make you very sick. Well, the spike protein is made up of all kinds of little protein molecules. And if you picture the surface of that spike protein, there are lots of little, you might think of it as like little tiles all around this thing. It's covered with these little tiles, and every little tile is different. And when you make antibodies, that is, when you've been vaccinated or you've had previous infection, your body makes these antibodies, and they're like little missiles that will go in and hit that spike protein. But every missile can only stick on one little tile. Every missile has one tile that it has to find. And so if you've been vaccinated with a vaccine that produces lots of those missiles, of a high variety of those, and they come shooting at that spike protein, well, a bunch of them are going to find their little place and stick and kill the spike protein. But if you only have a few different types of antibodies, they don't have a good chance of killing that spike protein. And that's actually a good way of thinking about it, because if you've got antibodies or immunity from prior infection with a coronavirus, you've got some immunity from having that infection. But that immunity is pretty narrow. You only have a small number of different types of antibodies to that. And so that's not very good immunity. It will protect you to some degree, but we know that the Omicron is very good against those, because the more mutations that virus has, the more those little tiles are changed. And then when they're changed, if your little missiles come firing at it, they won't recognize any of those tiles because a bunch of them have been changed. Okay, and the Omicron, turns out, has 3 times more mutations than Delta or Alpha or any of the previous variants. The previous variants have like 10 or 12 mutations, whereas the Omicron has about 50. And so lots of those little tiles on the surface of the spike protein have been changed. And so if your antibodies from a prior infection come along, they're not going to recognize anything, and so they're going to bounce off. Now, the vaccine, on the other hand, produces little missiles against many of those tiles on the surface of that spike protein. If you get infected with Omicron, your antibodies are going to be able to stick, even though many of them are mutated. The majority still aren't mutated, and so all these antibodies will still be able to outcompete the virus and kill it. And the booster, what it does, it not only boosts back up the amount of each antibody, when it does a good job of that, but it also increases the variety of these antibodies, and will then be much more effective at counteracting the Omicron than without the booster or immunity from prior infection.
You know, for our listeners, currently we have obviously the PCR test, we have rapid test, we have rapid at-home tests. But here is the real question. If they get tested, do you think our current test would detect the Omicron virus?
Yes, definitely. That's what we're seeing in South Africa and here, is that our tests are plenty good to pick up the virus. And the reason for that is the tests test for 3 different parts of the virus. And the spike protein is the one that's mostly affected by the mutations, but it's also testing against what's called the nucleocapsid, that is an internal part of the virus. And then a third thing it tests for is the replication apparatus, the part that allows the virus to reproduce itself when it gets in a human cell. And so we test for 3 different parts, and the spike protein is mainly the one that's being changed by mutations. But it no longer detects the spike protein part because it has changed so much. None of the variants before have done that. But the unique thing about Omicron is we only pick up 2 of them. In fact, that's, I believe, how they realized they had a new strain in South Africa. Suddenly, a bunch of their tests were only picking up 2 of those regions and not 3. And then they did the full sequencing and found out, yes, this is a new variant with 3 times more mutations than any variant they've ever seen. So it was a dramatic finding, but I think the clue was that the test was only picking up 2 of the 3 domains, but 2 of the 3 is plenty to pick it up. So our tests are still quite good, but that's a simple, quick way of suspecting that you've got the Omicron variant. But it needs to be confirmed by sequencing, which our academic laboratories are doing.
That's the question I have. Are there people testing positive, you think, potentially for COVID-19, but that subsequent sequencing testing isn't done, so they're being treated for COVID, but they actually have the Omicron?
Yes. So far, we don't know how the treatments are going to work against Omicron. Of course, the treatments, most of them have nothing to do with what virus you've got. I mean, once you're in the intensive care unit, they're very, very good treatments to keep people alive, and they still save most of the people. Now, what's new on the scene is we have 2 new antiviral drugs that are being reviewed right now by the FDA that may make a real big difference and what might be very effective in treating them. Those aren't available yet, but they may be coming in the next few weeks. And we expect those will be very good against Omicron.
You know, that's a very good point. Let me back up a little bit and kind of rephrase my question. Let's assume I go to a test site and I have a PCR test and it comes back positive. What would trigger the need to do the subsequent testing to determine if it's Omicron? For example, we just heard in Texas a lady test positive for Omicron. How was that determined to do that additional sequencing testing?
Well, the sequencing is actually a bit laborious and expensive. It takes highly trained laboratory people with very sophisticated equipment, so not every place can do it. And so they can't test every strain by any means. So what they do is they take a sample of people who test positive and they collect their viruses and then test them. So we never test everybody.
Got it. That makes sense. You do a random sample.
Yeah. Actually, it's not a random sample because that takes too much time. It's a convenient sample, but it's enough to give you a real good idea of what's going on with some inaccuracy, but it tells you where the thing is present, whether it's increasing or decreasing, and that's what we want to know.
This is Dr. Robert Haley from UT Southwestern Medical Center. This whole interview is also on our podcast, The Human Side of Healthcare. Dr. Haley's thoughts on what COVID might look like in the future. That's next.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're back with one more segment with Dr. Robert Haley, professor of internal medicine and the director of the Division of Epidemiology in the Internal Medicine Department at UT Southwestern Medical Center. His career spans nearly 5 decades, including 10 years with the CDC. If you'd like to hear the whole interview, it's on our podcast, The Human Side of Healthcare. Steve?
So, Dr. Haley, with your experience and even working at the CDC, let's look at history. The great influenza in 1918, started as an epidemic. Then it became pandemic. Now, flu is endemic. We get a flu shot every year. Is that what's going to happen with COVID-19, you think? It's going to become endemic?
Of course, nobody really knows. We're trying to predict the future, but most likely that is what's going to happen. In fact, if you look back at the history of that 1918, 1919 winter worldwide pandemic of influenza that occurred, that was the most deadly pandemic known to man up to then. It was really, really terrible. But what we saw is over the course of the epidemic, third or fourth or fifth wave, the virus did become less dangerous and less deadly. And I think that's what's going to happen to this one. In fact, we may be seeing it with Omicron. We may be seeing finally a little moderation of its virulence, the ability to kill you. You wonder why that happens. Well, I think it has to do with the evolutionary cycle. The reason that evolution happens, the reason that viruses and other species change over time is to increase the likelihood that they will survive and reproduce so that their species will continue to exist. And so viruses we've seen rapid evolution, strains that become more and more infectious because the more infectious ones that appear then take over, and that's the evolutionary process. So it's in the interest of the long-term survival of a viral species for it to become more infectious. It's not in the interest of the species to kill its host. The fact that it kills a human that it infects is not good because its home dies and they die. So that's counterproductive. So we don't expect them to become more virulent over time. If anything, that they might become less virulent so that the host that they infect stays alive and allows them to reproduce more. Because the longer they reproduce, the more likely they will to produce another variant that's more infectious. So I think that's why the natural history is most likely this will eventually become less virulent. Another factor is that this virus doesn't tend to affect little children very much. It's not very severe, but it can spread in them. And so we think what happened to flu and what happened to previous coronaviruses, by the way, this isn't the first coronavirus we've seen. There are 4 others that are known that probably started out as pandemics like this. It might have been very severe, but we don't know the history because it was too long ago. And what happens is, at first they go spread around and as they affect adults, and so what they kill a lot of people. But eventually they stop spreading and maybe go away for a while. But then when they come back, they first affect the children who have been born since the last epidemic. You see, but the children don't get very sick, but all the children develop immunity. So as they grow up, they are immune. So adults don't tend to die, except for the few adults who escaped infection as a child. If they get it first as an adult, and we do see occasional galloping pneumonia that we don't understand, that we can't treat, and that may be one of these people who somehow escaped being infected as a child and then do badly. And if that's the case, then this coronavirus, the COVID-19, will eventually become an endemic one. It comes back every year or 2 or 3, produces common colds among all the children, but everybody else is already immune, and it'll join the other 4. It'll be the 5th coronavirus that causes common colds. That would be nice, and we hope that's what happens.
Dr. Haley, as always, you give us great answers, good advice. I'm going to pause and see if Thomas has questions he would like to ask.
Thanks, Steve. I'm curious on the scale of from original COVID 2 years ago to where we are now. And here we are talking about variants. Which of these variants has been more deadly to the community?
Well, interestingly, that's pretty easy because they really differ more in their ability to spread, to be their infectiousness. They're very, each one, successive one has gotten more infectious, but their virulence hasn't changed much. But of course, the more infectious it gets, the more people it's going to infect, and so it's going to wreak more havoc. But the virulence is really, if you take 100 people, what percentage of those will have to go to the hospital and what percentage will die? That's sort of the definition of how virulent they are.
Why do you suppose, your opinion now, because obviously we can't get into somebody else's mind, but people are getting together in tight enclosed spaces a lot and not wearing masks? Why do you suppose?
Well, that's a very interesting question, and that's always been the case. You know, public health measures are things in any setting, are things that public health people have learned are helpful to allow people to avoid illness, and their recommendations are followed by many people, but there have always been groups and people who don't do it. In the past, I think that has been much less common now. It's got a lot more common in this particular setting, and I think, unfortunately, it's because this has been politicized. It's become a way that some people identify with their political party, and that's very, very unfortunate. We need to back off of that and realize that it doesn't help a political party for more of its members to get severe illness and die. And it's just sort of coincidental, I think, that happened, but had very severe consequences.
Yes, it certainly has. There's no shame in walking into a store or a restaurant or a venue with a big old mask on, in my opinion. I do it all the time. So, and that's another question. So some people have basically been living life almost unobstructed since the beginning of this. I mean, maybe they're wearing a mask, maybe they're not, but they're flying on airplanes, they're going to hotels, they're going to restaurants, they're going to shows now, venues, all kinds of things, and just not missing a beat. And they don't get COVID. And somebody else goes to one silly little party, takes their mask off to dance, and boom, they get it. Any idea what the difference is between the one who gets it and the one who doesn't?
Yeah, luck.
Yeah, no kidding, right?
Yeah, I mean, look, we've known this forever, that risky behavior leads to serious, severe, regrettable consequences, but only for a small percentage of people. Most people who do risky things get away with it, maybe for all their whole life. But the more risky things you do, the greater chance you have to suffer serious consequences. You see many people getting away with it, but, you know, if they were the unlucky ones who didn't and ended up in the intensive care unit, you know, there's another epidemic that we've seen. Anybody who's worked in a hospital or intensive care unit has seen that deathbed regret of saying, "Doctor, I wish I'd worn a mask. I wish I'd gotten my vaccine. Can you give me the vaccine now?" I mean, that's just a common conversation to have in the hospital, of all these people who took the risk, who gambled and lost, and now are regretful and wish they had done it differently, but it's too late. But that's just the way it is with risk taking, and in fact, I think in a religious sense, you would call that sinning. People who commit sins mostly get away with it, but occasionally they don't, and they regret.
You can't turn this thing around, that's for sure. So I'd love to just peek inside the thoughts that you might be having here as we're concluding this year, rolling into year number 3, without this thing going away. Your history, you worked with the CDC for 10 years. You were very active in this field during Ebola. You've seen them all. You've had a long, successful career. As you look back on this, what are some of the things that go through your mind?
Good question. I think one of the things that has struck me is the place of public health in our society, in our country, and in society in general. You know, public health is basically a political football. The purpose of public health is to learn what is causing disease and what we can do about it, and then develop ways of helping people stay safe from severe risks to their health and their life. Teach them those things, and then try to get people to do the things that keep them safer. The problem is there are different political philosophies about how much the government should help people stay safe. And so some people think that it's a legitimate place for government to spend taxpayers' money to carry out public health, to keep our population safer and more productive. And other people think, no, it should just be personal responsibility, and we don't need the government to fund public health. And so what we've seen over my lifetime, and having studied this throughout the 20th century and into the current century, we've seen the commitment to public health, to epidemiology and public health departments rise and fall, wax and wane. And there are periods when we put a lot of resources into public health and our population gets safer and healthier. And then we go into periods where we starve the health system and it fades back into the background, and then we start getting epidemics and things spreading around and people dying, and then the cycle repeats itself. And I wish there was some way of avoiding this cycle, but it goes on and on.
Thank you, Dr. Robert Haley. We hope that hearing that conversation helps re-stimulate some of the foundational principles that we've been talking about for 2 years. When we come back, a heartwarming story about how a family honored a healthcare team at one of our hospitals with art, next on The Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. You know, Thomas, we spent 3 segments with Dr. Haley, but that was so important because we've got this new variant and people are very concerned about it. You know, this Omicron variant is rearing its ugly head right when we were hoping to be tamping down COVID-19.
Yeah, it's like, we want it to go away. We want our lives to get back to normal. What a great way to transition from 2021 to 2022 by saying goodbye to COVID, and it's just not going to be there for us. And Dr. Haley's experience, as we've heard, is just so extensive that it's almost like when he talks, you want to lean in and listen.
You know, you really do. You want to listen to him. He talked about prevention, but unfortunately, sometimes people still get COVID and they end up in a hospital. And that's when our healthcare heroes really step up. We're now going to deal and talk with a situation where a family was so appreciative of the treatment they received that they actually painted a picture of the staff.
You know, this is so cool. I mean, you and I have both worked in hospital environments and medical clinic environments, and people want to express their thanks and gratitude to their providers. It's just a tradition. You want to thank your doctor. You want a doctor on your side, right? You want to say thank you. And typically it's maybe some food or a plant or something like that, but never have heard of somebody wanting to paint a painting that is now on display up at Presbyterian Hospital, the Texas Health Presbyterian Hospital in Plano, that you can go see. And we are going to now tell that story about the family who was so touched by the care they received that they wanted to say thank you with art.
We're going to be talking with Percy Paclibar, and Percy is a critical care nurse that works in the medical surgical department at Texas Health Presbyterian Hospital located in Plano. Percy, welcome to the show.
Thank you so much, and thank you for having me.
You know, Percy, you and your team do such a great job of taking care of COVID-19 patients. I know there was one patient in particular, Mario Cortez, that you nursed back to health. His family was very grateful. In fact, he gave his permission to tell his story about a gift they gave the staff. Can you tell us about that gift?
Yes. So Mr. Mario Cortez was one of our patients on the medical telemetry floor. He spent 10 days there, and then he got better. He He fought COVID and he won the battle, and he got discharged home. During that time, we have been in constant communication with the Cortez family, specifically his daughter, Susie, because one of the things that are challenging during that time was the visitation. So during that time, COVID patients cannot have visitors. And so what we did was we would just update family members through the phone or through FaceTime or through video, telling them the updates about the patients. Also, that gave the patients and the family to interact. Well, after Mr. Cortez got discharged, he got sent home. We received a communication from Ms. Susie Cortez, his daughter, that she was very appreciative of the help that we have given to Mr. Cortez. So she sent us a picture of two nurses with a mask, and this is it's like a painting, but it's in a photo, and there was a handwritten note from the artist, Susie Cortez. And then following that, she reached out and she said, I would like to do more for the healthcare team that took care of the father during that time. So she came up with an idea and asked for a permission if we could send her photos because she wanted to make a painting of the healthcare team, representing, the healthcare team and how the teams of nurses, doctors, and other healthcare professionals helped her father fought through the COVID-19.
If you would like to see the painting that we're talking about, search Mario Cortez Plano painting. Some of the stories even have the picture of the care team with the painting that are really cool. So, Percy, what emotions do you feel when you think about this honor for you and your whole team?
Well, it feels really good. It feels great. I feel grateful. I guess I could say that that's just a small representation, or it could, if I may say, that's just a representation of the healthcare workers worldwide that really work hard day and night to make sure that we're taking care of our patients, specifically during that time that we had the COVID-19 pandemic.
Percy, when the healthcare team walks by and sees that painting, it must really help their morale and encouraging them to continue the good work they do every day.
Yes, I agree. It's a unique gesture from a patient because normally people would get a card, a letter from patients and family, which we truly appreciate. But this painting is something that's unique. To be in a painting, we feel grateful as nurses, as physicians, as healthcare workers to be in the painting. Again, it's something unique, a gesture of being thankful for the care that we gave the patient.
Percy, COVID-19 has had some days where people are down, but let's focus on the positive. What really makes a positive day at Texas Health Plano?
What stands out about Texas Health Plano is its culture. Texas Health has the promise of caring for individuals together. That is something that is really being lived by, not just by the employees, but as well as the leaders that we have here at Texas Health Plano.
COVID-19 has impacted everyone. We've had to adjust to a new normal. The pandemic is certainly uncertain. So what keeps you grounded? And not only grounded, but not venturing into another career?
That's a very good question. Well, and I've been asked that question several times, even by my friends and some family members. But personally, I love what I do. If I would do it over again, if I'm in the point of choosing what career path I'm going to do, I would still be a nurse. And just because I truly believe that nursing is both a profession and a vocation. You do things, to take care of patients, but also you do things in an aspect of being a human being, taking care of another human being. And that's what keeps me grounded. I came from a family of nurses. My wife is a nurse. My oldest son is also a nurse. He's also an IC nurse. And I love the conversation at the, at dining table at night when we talk about how did our day went that day. And it was just amazing feeling being in this profession. So to me, having the passion that I have for the profession and having the love that I have for mankind, I guess. And to me, it's the best profession.
Thomas, we've had a great show today. I know people are very concerned about Omicron, but let's end this show on the positive. Look, we're all in this together. We've been down this road before. We're going to beat COVID-19, and we're going to enjoy the upcoming holiday at the end of the month.
One of the things that I hope, Steve, is this holiday season that we can continue to all come together. This thing has been so divisive on so many fronts, and why not, like you say, let's take a positive on this and spin on our heels, and let's love each other and accept each other for where we are. And then, like we heard Dr. Haley so eloquently say, do the things that we need to do collectively in order to stomp this thing out.
That's called good public health. Thomas, great show. I hope our listeners will join us next week. We're going to talk about safety with toys over the holidays with your children.
There's a little tiny thing in some of your toys that could actually put your children on the operating table to get it out. And we'll tell you all about it next week on The Human Side of Healthcare.
Stay safe, everyone. We'll see you next week.